Welcome to a new episode of Medicine in 10 minutes. We go straight to the point. The subject is bravely made clear and often illustrated. Let's start. Today's topic is about Bell's palsy. To fully understand the facial palsy, it is necessary to provide an anatomic reminder of the facial nerve, its origin and its section. Then we move to GSPN palsy, stapedius palsy, chorda tympani palsy, terminal branch facial expression palsy, fracture of the temporal bone. Then we move to upper motor neuron lesion versus lower motor neuron lesion. Then Ramsay's hand syndrome, schwannium, and then Bell's palsy. Brachiomotor send ischius stimulation to muscle of facial expression. GVE from superior lacrimal salivarius send stimulation to lacrimal gland via great pertorsal nerve. Efferent from the air go to the trigeminal nucleus via GVR and taking simulation of temperature, touch, and pain. Best sensation are sent to solitary schnettus via ischia fiber. Face start with meatus segment, then labyrinthic segment, then tympanic segment, then mastoid segment, then stylomastoid foramen. From geniculate, great pertorsal nerve go to lacrimal gland. Brachial motor going to stapedius muscle, then chorda tympanic muscle to sublingual and mandibular gland. Muscle of facial expression through the stylomastoid foramen. The first lesion is before the geniculate ganglion. GSPN, greater superficial pectoral nerve, difficulty in closing the eye. We say crocodile tear syndrome. Shedding of tear while eating. Six or abducens nerve palsy, horizontal diplopia. The affected beyond midline eye is unable to abduct. A lateral rectus muscle don't abduct. Why? Because the nucleus of 6 and the nucleus of brachiomotor 7 are close each other. Second lesion beyond the ganglion geniculate. Stapedius muscle inside the pyramid is attached to the neck of stapes. When there is loud sound, stapedius muscle contract, causing the tilt of the foot of a plate of stapes to restrict the movement, preventing the inner air from excessive stimulation. It's a protective reflex for higher cell. The muscle contract also when a person talks to avoid to hear much for himself. When there is Bell's palsy, the reflex is lost. Stapedius reflex is lost. The third lesion is before chorda tympanic. Chorda tympanic 2/3 anterior tongue. Salivation because submandibular and sublingual. Anterior 2/3 tongue will lose gustative sensation ipsilateral half. The fourth level is before the stylomastoid foramen. The facial brachiomotor command muscle of facial expression. When there is a palsy, there is a deficit in expression of facial muscles. In blunt trauma, the facial nerve is most often injured. Fracture of the temporal bone causes acute paralysis of facial nerve. It could be a transverse fracture or longitudinal fracture. Transverse fracture in 40 to 50%, longitudinal fracture in 20%. Mild injury are treated like Bell's palsy, protect the eye and white. Serious lesion, nerve conduction study. In case of direct injury to the nerve, surgery. Edema and inflammation secondary to traumatism, give steroid. How to differentiate upper motor neuron and lower motor neuron lesion. Central facial palsy is characterized by paralysis of the lower half of one side of the face. It usually results from damage to the higher motor neuron of the facial nerve. As a result, central facial palsy is characterized by hemiparalysis or hemiparesis of the contralateral facial expression muscle, but not for the head muscle. Upper motor lesion, contralateral lower false palsy. Lower motor lesion, ipsilateral hemifalse palsy. Facial problem and hemiplegia are crossed. Lesion at Fontaine, facial level will be completely lost. Facial problem ipsilateral, upper and lower half. Motor fiber descending to pyramid tract, system that goes contralaterally in pyramid medulla. Contralateral hemiplegia. Ipsilateral face, contralateral hemiplegia. From trigeminal nucleus GVA go to geniculate ganglion and synapse. From that synapse, the postsynaptic is going to the ear, and this synapse is the location of reminiscence of herpes after a primo infection of herpes. It could cause a Ramsey syndrome, Ramsey-Hunt syndrome, by compression of fiber in facial canal by edema. Lesion in the geniculate ganglion most common is herpes zoster, Ramsey syndrome, intense burning pain in the air, vesicle and hemorrhagic fluid in the middle air, low motor neuron lesion. Nuclear lesion, mainly brachiomotor or facial, almost 6 nucleus lesion, ipsilateral horizontal gaze palsy. 6 and 7 are close to each other. Facial nerve fibers are present first within the nervous central system before they go outside. Central part is oligodendrocytes attached by multiple sclerosis, low motor neuron lesion of facial nerve within pontine substance, never outside the central nervous system, by Schwann cells. When nerve is entering the acoustic meatus or traversing internal auditory meatus, it's Schwannium neurofibromatous type 2. 6 and 7 brachiomotor are closer each other. Schwannoma bilateral 8-nerve tumor, hearing loss, nerve compression, headache, facial numbness, poor balance, and tinnitus. Thank you for watching this episode of Medicine in 3 minutes. Make sure to click the button like and subscribe. Your comments are very welcome. Thank you.